Good evening. My name is Randall Cohen and welcome to Viva Learning. Thank you to Viva Learning for the opportunity to make this presentation, and thank you to Septodont for your sponsorship. This lecture is entitled The Biomimetic Restoration, a Paradigm Shift. All of us recall the long-standing admonition from dental school that the operator must end the margins of the casting only on sound tooth structure. And while this concept seems to be foundational to successful restorative dentistry, recent research and experience suggests otherwise. The opinions of many clinicians have been undergoing a paradigm shift in how they should restore teeth, moving away from the full crown that has long been the mainstay of clinical practice. This concept of a multi-component restoration has a particularly useful application in the treatment of decay and fractured teeth, often of which will present a difficult clinical challenge. Oh, excuse me, I'll just back this up one more. I just wanted to note that we are going to examine today the potential to create a restoration that will replicate the biologic and the elastic properties of the intact tooth in what is now being termed biomimetic dentistry. Now, in doing so, the clinician no longer attempts to extend the margin of the casting beyond the composite buildup into a single component restoration, but instead takes advantage of the tight seal of composite to dentin at the gingival third and the ability of composite cement to create a secure bond to an existing composite biobase. This departure from this one-piece crown has tremendous implications in simplifying the procedure, in creating a more biologically acceptable restoration, in avoiding periosurgery, and by creating a fail-safe design that can be more easily repaired in the future. Dental hard tissues each possess a different flexibility. You have the hard enamel on the top, you have softer dentin underneath, and they each possess a different flexural modulus. So the result in a natural tooth is a biologic structure that has some bendability, but yet some wear resistance under function all at the same time. The differential between the higher stiffness of a cast metal or metal porcelain crown relative to the more flexible underlying tooth transfers occlusal forces to the gingival margin, the exact place where the weakest part of the crown is located biomechanically. So this inflexibility puts the casting at odds with the physiologic bending of the tooth, and so the occlusal stress is transmitted to that margin, and that's where we get our failures. Here we can see we have a stiff crown versus a more flexible tooth substrate, which gives us that push-pull action. And so we end up with cement washout and failure at the gingival margin. We have open tubules, we have dead pulps, we have periodontal disease, and this is an example of that. If we look at the x-ray from this case, the bottom crown is the crown in question. When I removed it, this is all we had left. But full crown treatments can result in a whole host of problems, as we all know. And some of them are listed right here. In fact, in the Fundamentals of Operative Dentistry, in this textbook by Schmidt and others, the full crown is considered the least desirable treatment option. This is a case of mine that I had done about 18 years ago, where I had to place a full crown on the first molar, but I was able to put partial coverage on the second molar and on the second premolar. But look which tooth failed. It was the first molar. It wasn't because there was a poor margin there. It was because the occlusal forces were transferred to that margin and there was a failure. But this was before I knew anything about biomimetic dentistry. The partial coverage restorations survived beautifully and continue to survive to this day. what we are seeing here is biologic failure. And this biologic failure comes from a leaking restoration. It produces caries and cracks in teeth and propagation of those cracks, dead pulps, periodontal disease. And the problem is that it is often asymptomatic until it becomes catastrophic. Here we see peripheral rim fractures that have occurred in composite restorations where the bond has failed, and under function we have opened up, this patient has opened up a 50 to 100 micron crack from the distal through to the mesial. This is a pathway for bacteria to enter and to replicate. Decay like this is called occlusal effect caries, and it is certainly not coming from a failure to floss. Here's an example of a biologic failure that led to a catastrophic failure. The patient came in to see me with this, complaining that this particular crown continually came off. We can see a very short tooth. We can see a hole in the tooth from having had to have a root canal, and we can see periodontal disease, and if left untreated, that root canal will fail from a crown down micro leakage. Here's the other picture of the case we saw before, a catastrophic failure. This tooth was lost. There was no way to restore this, and this is all from micro leakage at the gingival margin. Instead, we want to create what we call a fail-safe restoration, where the caries is limited or none. We simply have a clinical failure of a material, something that is easy to repair, and that the whole restoration is preserved. Think of it as fail-safe or fail-friendly. And here's an example of a fail-safe restoration. The patient broke off a corner of this partial coverage porcelain biomimetic restoration, and all we need to do is roughen it a little bit, and repair it with composite. This is what we want. Since nothing in this world lasts forever, we want things to fail in a friendly way, not in a catastrophic way, and this is an example of that. Biomimetic dentistry creates these fail-safe restorations, as opposed to the catastrophic failures that can occur with full crowns. Biomimetic dentistry mimics the biological and mechanical properties of the intact tooth, and that's where this word biomimetic comes from. The objective in the biomimetic strategy is to replicate the intact tooth mechanically and biologically. We accomplish this by replacing lost tooth structure, the enamel, the dentin, and the DEJ, using similar materials with a predictable methodology based on science. It is useful for endodontic as well as for vital teeth. Dr. Pascal Magnier, one of the innovators of biomimetic dentistry, states that the aim of this strategy, and this is very important, is not to create the strongest possible restoration, but rather to create a restoration that is compatible with the mechanical and biologic properties of the underlying tissues. It does us no good to have a rock-hard crown that will not break, only to have the tooth substrate under it fracture irreparably. Biomimetic dentistry eliminates infections and cracks in dentin. It involves immediately sealing that dentin, bonding the tooth from all directions, creating a lowered stress and strain in the tooth and restoration. We want to resist subsequent loss of tooth structure, and we want to match the tooth's functional anatomy. We do that successfully, we will have very long-lasting restorations. Think of successful adhesive dentistry as an equation between bonds and stresses. When the bonds are able to withstand the stress, we have a successful result, and in the converse, we have a failure. And we will be looking at clinical cases, and we will be playing the movie backwards to try and figure out what happened and how those restorations failed. Let's talk about some advantages of biomimetic cast dentistry, just simply from a procedural point of view. What we call the biobase, which you may think of as a core buildup, is done without tissue bleeding into the field. We don't have to we don't have to fight the bleeding tissues in order to get a dry field. Post-op sensitivity is eliminated or really reduced in occurrence to rare and very minimal. The preparation is very simple. You can see it on the top slide. The impression making is also very simple. Believe it or not, we do not need provisionals. The surgery to lengthen the clinical crown is often not necessary. In my experience, and I have been doing these restorations since 2008, I find that we have minimal adjustments of contacts and occlusion at the insert visit, and there's no anesthesia needed at the insert visit. And it's very easy cleanup at cementation, making for very healthy periodontal tissues. This conservation of tooth structure eliminates postoperative sensitivity in vital teeth. It preserves the tooth's flexibility. It creates a low-stress, cleansable restoration and avoids unnecessary endodontics. Biomimetic dentistry is taught as in 6 concepts, or the 6 lessons, as created by Dr. David Alleman, the director of the Alleman de la Perry Center for Biomimetic Dentistry in South Jordan, Utah. These are the 6 concepts, and we're not going to have time to go over all of them. It is a several-day course to go over all of them, but just to list them for you in order of importance. Caries removal is lesson number 1. Removal of structural compromises, which are the cracks in dentin, is 2. Development of a secure dentin bond, lesson 3. C-factor control, lesson 4. Onlay preparation and enamel beveling is 5. And lastly, making certain that we have occlusal harmony is lesson 6. They are in order of importance 1 through 6, but their order of treatment is somewhat different, as we will go through in our clinical slides. We start with lesson 2, removal of cracks and structural compromises. Now, opening up this tooth, we can see cracks into dentin from 4 different entry points. And what we're going to do is we're going to chase those cracks under magnification with a big round burr. We do not try to chase them with a little 1/2 round burr, because all we do is create weak points there. We open them up wide with a number 4 or number 6. If the cusp is undermined, we remove it. If the crack extends deep, we have to use our judgment and stop before we expose the pulp, because it is not a biomimetic concept to expose pulps. One of the important things is when we're dealing with caries removal in lesson 1 is the end point, or when do we stop? And the importance of the general objective is to maintain pulp vitality. We want to eliminate this dentinal infection by removing, deactivating, or sealing in bacteria. We want to conserve intact tooth structure. What we do is we create the peripheral seal zone, which consists of normal dentin, the DEJ, and 1 to 3 millimeters of enamel. And we confirm this with caries detecting dyes, such as caries detector solution. This is the particular one that I use in my practice. It's made by Kurare Noritake. It's a red stain, and you will see a red stain which will indicate infected dentin, and a light pink stain for the affected. And what we do is we leave the light pink haze, because that means we're getting very close to the pulp. So we leave the pink haze, and that way we avoid pulp exposures. These are our treatment goals as expressed by Doctors Alleman and Monnier. And, the most important thing is not to expose the pulp, so we leave that pink haze in. We seal in and deactivate any remaining bacteria left inside of that peripheral seal zone, and that peripheral seal zone is absolutely clean and clear of bacteria. And we use a restorative technique that will maximize the bond strength so we don't have an interface failure of the material with the dentin. Moving on to lesson 5, we can see our onlay preparation and enamel beveling. And really what we do is once we have removed the decay and once we have removed the cracks, we're going to take down these cusps. We turn the handpiece on its side and we take the cusps off. What we're going to be doing here is the concept of raising the box, and we'll talk a little bit more about that in lesson 4. And then once we have raised the box, we will restore the case here rather than try to go past the composite into the gingival sulcus. We create these proximal boxes as we have done in our entire careers, and many times as we're building up a tooth from the proximal box on upward, I would think to myself, wouldn't it be nice if I could just leave some of this and not have to go past it into practically into the attachment where there's bleeding and potential encroachment on the biologic width. And that's what we mean by raising the box. So we will be restoring the case up high rather than down low. Lesson 3, what I want to just say about lesson 3, it's important to establish a secure dentin resin bond, and there are 2 strategies to do that, the total etch or the self-etch technique. The total etch will remove the smear layer, demineralize the dentin, and open up the tubules, and that is the mechanism by which the resin is able to create a bond. And the self-etch maintains the smear layer, keeps the dentin in its mineralized state, and the tubules stay occluded. Lesson 4 is something important, and that is C-factor control through slow start curing and the use of Ribond. Ribond, we will talk about that in a moment. C-factor, or the configuration factor, is the ratio of the bonded surfaces to the unbonded surfaces. Class 1 and Class 5 preps have very high C-factor. There's a lot of walls around those preps. And obviously a single surface restoration like a veneer or a Class 4 has a very low C-factor. But what's important is to use low shrinking materials to minimize the internal stress that occurs when these composites are curing. These setting composites do create stress, especially early in the cure cycle, so we're going to do the slow start curing. We give it a slow start on the light from about an inch away, and then we wait, and then we finally finish the cure. More details of that are available, but I just did not want to go into the exact details of how long you wait and how you do that. However, there is a specific technique that we need to follow with the slow start cure. Many of the current resin composites have 2 major problems. One is that there is a poor conversion of the monomer into the polymer. And second, there is significant polymerization, volumetric shrinkage, and the shrinkage stress. Now the matrix, the resin matrix that makes up these composites has not changed in 40 years. The filler products have, and there have been many wonderful changes in the fillers that allow for better polishability and better strength. But up until now, the resin that the filler particles are embedded in has been all the same, this GMA resin. This composite that is made by Septodont called Endurance has an updated resin system, the dimmer acid as opposed to the BIS GMA. It gives you a lower volumetric shrinkage and less stress and a higher conversion rate, and this is very important when doing biomimetic dentistry. We use flowable composites as bioliners, and it's important that they not have a high shrinkage factor to them. Endurance also contains updated fillers, 81%, which is a pretty heavily filled product, and that allows it to be handled well, which is very important, especially in when you don't necessarily have the advantage of a matrix band. Ribond is a high molecular weight polyethylene fiber. It's a ribbon, and many of us are familiar with it in terms of splinting teeth, but we use it to pressed against the dentin floor, and by doing that, we help divert occlusal forces. So where we have potentially a crack right in the middle of the occlusal surface, we can mute some of those occlusal forces, and it also takes up some of the polymerization shrinkage. So it protects in two different ways. The DEJ, the tooth's structural integrity center, is a three-dimensional, and it is the collagen of the dentin united with the collagen of the enamel. And what the DEJ does is it provides that flexibility and some energy absorption. And that is what we are recreating with that Ribond bioliner. The BioBase recreates this DEJ and its bendability, and it is this DEJ that is contributing to the fail-safe mode of intact teeth. We all know that intact teeth almost never, not never, but almost never fracture. So what we do is we create this bioliner and biobase. We replicate the intact tooth, the DEJ and the dentin, with materials that have similar properties as the natural tooth structure. So let's go on to some clinical cases. Here is a patient, a young lady who drove about 2 hours to see me because she'd heard about biomimetic dentistry. She had had unhappy experience with losing a number of teeth after having some very aggressive dentistry. That is a large composite with a big hole in it, and if we play this movie backwards, we can probably determine that the operator loaded up that tooth with light-cured composite in one big bolus, then cured it, and there was probably unset composite at the bottom, but there was a huge amount of internal stress that developed. The bond was lost, part of the tooth, and the restoration was lost, and we have deep recurrent caries. But we have an intact facial and lingual aspect to this tooth. We also have you can see some abfraction lesions, so this patient has some occlusal issues as well. A crown margin down at the gingival margin will not do well in a case like this. So we open up the tooth, and here is mush inside there, just infected dentin. Infected tooth. The tooth structure is soft, and we place the caries detector solution on top. We rinse it off, and we have red areas and we have pink areas, and we clean them up such that we have clean, sound dentin here. And fortunately, we were not. We were able to do this without getting near the pulp. But now we have the internal portion of this tooth is cleaned out, and we are ready to begin building our biobase. You wrap a matrix band around it, a wedge where needed, and what you can see that we do here is we build the proximal walls of the biobase first. We build the 1 millimeter wall up on the mesial, a 1 millimeter wall up on the distal, and then we place our Ribond against in the middle of the tooth with some flowable composite. By building the walls up by themselves, we are eliminating a lot of that contraction force, but we are also enabling the light to get all the way down to the gingival margin. If you just load a tooth up from the bottom up and then shine your light on it, most likely that gingival margin is not getting light cured. This is our preparation. You can see it from the occlusal on the right-hand side of the screen, from the facial on the left-hand side. I know the patient needs a little bit of oral hygiene. This was her first visit to me, and this is what she wanted to get done. So we went along with that. But following all this, obviously she's going to need a little bit of oral hygiene instruction and periodontal treatment. Here is the case ready to do our bonding. That is the preparation. I like to put the rubber dam on whenever possible, especially on lower teeth. It makes it much easier to do the insert. I take the casting, I put it onto a cotton-tipped applicator with a little bit of Dilar wax that enables the assistant to load the crown and pass it to me very easily. So here you can see we're seating it onto the preparation, and there's our final restoration. You can see that we have preserved the gingival 2/3 of this tooth where the hard biomechanical forces are transmitted, and also we keep away from the gingival tissues. The proximal boxes have been restored carefully with flowable composite that has like angstroms of a gap between the composite and the tooth structure, so we are not concerned about bacterial microleakage, and the composite material is flexible, so we are going to have a long-lasting restoration here. Let's return to this case that we showed at the very beginning. If you remember, the bottom was the crown that had failed and the tooth had to be lost, but if you look at the upper molar, you can see root caries, and root caries is a problem. And most likely the bottom tooth had the same kind of root caries that this one did, and ultimately it ended up with a root canal and a crown and a failure. So let's see if we can avoid that same problem in treating tooth number 14. First thing we do is access the superficial caries, and then we can see down in that proximal box we have some deep caries. So going down a little bit further, with our flat-ended shoulder former diamond, we are down into well past the gingival margin, excavating decay. Up on the top is just simply stain. I'm not concerned about that. And full caries debridement, where we are about 7 millimeters below the cusp tip. So you have from the bottom of the prep all the way to the cusp tip, you have about 7 millimeters, which is a pretty long distance. We then go to lesson 5, our preliminary onlay prep, where we shorten these preps. You can see I used articulating paper to make sure that I had enough clearance so that there's no contact. We wrap a matrix band around tightly, and we do our bonding procedure with our self-etch bonding agent. The bonding agent that I like to use for cases like this is DC Bond from Karori Noritake. It is it's a self-etch adhesive, 2 bottles, bottle A and B, into a single well. You apply it, wait 20 seconds, air dry, and then light cure. We then create our bioliner. You can see the little piece of Ribond on the top. There's another piece of Ribond you can put on the axial wall, using our flowable composite, the Endurance Flow, which is a very low shrinking composite. And we complete our bio base. Once the prep has been completed, we do immediate dentin sealing. We use the same bonding agent on the top. That way we prevent any sensitivity, and we create a better bond when it comes time to bond the casting on. Here's the impression is completed, and the patient is dismissed just like this. She does not require a provisional because we've had the dentin has been sealed. And when the case comes back, here it is on a contact model. We prepare the substrate by pumice and rinse, dry, and then we're going to use our resin cement. We load the casting with our dual cured cement, do a little wave cure, 5 seconds facial and lingual, and then for cleanup, we have a pretty easy time with this particular cement. It's called SA cement from Karori. It's a self-etching adhesive, very easy to clean up, and it's a very secure cement. Here is the final result. We have a tooth that had root caries, and we are restoring it without periodontal surgery and without endodontics and without a toothache. Here is the finished case. You can see this patient also has some abfraction lesions, and it really would not do very well to place a margin of a casting there at that at the gingival margin. And here we can see the final X-ray. On the right, you see our multi-piece restoration. We were able to seal the gingival margin beautifully with the composite and then place our porcelain casting on the top, replacing the enamel. Here's our catastrophic failure that we were talking about before. And we want to prevent that sort of thing from happening by making sure that these biologic failures do not occur. Now, what happened here? What happened here with this case was the same thing that happened in the other one. Somebody loaded up a prep all with light cure composite, cured it all at once, and basically had no bond at all. But we did have an asymptomatic tooth and a vital pulp. So here we are with lesson 1, removing caries and disinfecting the dentin. Here our dark red is the infected dentin, the pink is the affected, so we're going to remove the red and leave the pink. And here we're going to do our low C-factor layering to build the bioliner and the bio base. And you can see once this slide gives you a nice picture of building up those walls first, making sure that you get very good light penetration down to the gingival margin and very low stress incorporated into the composite. Here's our completed biobase. Here is our completed preparation and the final restoration. It's asymptomatic. We still didn't need a root canal. We didn't need periodontal surgery. This is repairable should there be a problem. This is a very instructive case I'd like to show. We talked about the occlusal effect caries that is occurring here. Now, I treated these teeth 5 years ago, prep, rib-bond, and biobase. In full disclosure, when the castings came back, I didn't leave enough room, so I had to re-prep them and shorten them a little bit more. And you can see the series of the sequence of treatment. And the castings went on. The patient was fine. Teeth remained vital. But 16 years ago, I had done the other side, and this was before I knew about biomimetic dentistry, and you can see the long and unhappy treatment that this took, periodontal surgery by the periodontist with multiple visits. Then she came back to me for core buildups and preps. These are classic GV black preps. She developed pain in them, so she ended up having to have root canals. We went to I referred to the endodontist, root canals, both teeth, cemented the castings. It took a very, very long time, but surgery, endo, multiple visits, and she stayed away for quite a few years. So really, when we compare the two sides of her mouth, she was much better served by the biomimetic dentistry than by the classic GV black. Another case, broken. We see these kinds of cases all the time. Here is the facial of this particular case, and I'm just going to show quickly how we use the cotton-tipped applicator with Delar wax to lift off the casting from the model. Here is our prep. My assistant is able to hold the casting by way of using this little stick. She loads it with cement, and we insert it onto the prep, wipe it down, cure it, and then we have a fully functioning biomimetic restoration. Here you can see the facial of it. Patient's very pleased with it, and you can see that we have preserved a great deal of her tooth structure. Another case, you can see on the premolar, cracks deep into the dentin, the molar, decay below the tissue margin. This is essentially what happens from large amalgams with a patient who tends to grind her teeth. The second molar had a crown done on it. The crown to date is satisfactory, but you can see that she is wearing it, and it is not the most ideal restoration. From the facial, you can see that she essentially has good tissues and pretty intact tooth structure on the facial. Remember, that facial margin is really the critical part of the tooth. That is the biomimetic part of the tooth that we must be very careful not to violate. Here are preps. They look like little domes. You can look on the lower part of the screen, and then you can look in the mirror in the top part of the screen, but you can see how these teeth are prepped. But take a look at the tissues. The tissues don't even know anything's been done to them. And here is our final restoration from the facial, and here is our final restoration from the lingual. These teeth, no root canals, none needed during preparation, and none needed subsequent. Sometimes we have to restore endodontically treated teeth, and when we do that, we are sometimes faced with this, submarginal caries. I had to remove the second molar, and then the patient came back a week later, and here she was with this previously endodontically treated tooth with submarginal caries, and we needed to clean up the decay that was in there and place some kind of a composite material in there so that when she's ready for her casting, we will still have a tooth left to restore. It will not fall apart on us in the meanwhile. So here I'm using the Endurance, and I like this particular material, although you can surely use other flowable composite materials. The one advantage here that I see with this one is that it doesn't run. So it is a very well-controlled flowable composite, and I build the proximal walls incrementally. I couldn't get a matrix band around that back part of the tooth, but that's okay. You can isolate it with cord if you need to, and then slowly build that proximal wall up with flowable composite in 0.5 millimeter increments. And here is the technique for it, 0.5 millimeters at a time. You want to use the low shrink flowable composite. But remember, the build-up walls the walls are good. They're only 1 millimeter thick, so you are getting very good conversion of this entire structure from monomer to polymer. And you're using a high gloss composite, so you don't even need to worry about polishing. Here is the completed distal wall, and once you have this done, the rest of it is easy. We're going to place what I did in this case is I used the rib-on in the canal space. Just note, I have not placed a post in a tooth since 1997. Posts are very destructive to teeth. They are totally unnecessary. They make root canal retreatment very difficult, and I don't use them. But what I do sometimes is I will place rib-on into the canal space. Soak the rib-on, so a 16 millimeter length of rib-on, soaking it into the composite resin, placing the middle 8 millimeters into the preparation of the canal. You prepare the canal down 4 millimeters. You stuff in the middle 8 millimeters of the rib-on, and then you cure it, and then you get a rib-on post in a way. It's like a fiber post, and you can see the ends of the rib-on coming up, and that gives the composite a matrix to bond to during polymerization. Here's the final preparation there. Minimal tooth loss from endodontic restoration, very simple really. Here I just simply use zinc phosphate cement to close the canal, and here is you can see the final preparation, the casting going in, and then on the bottom that is the final casting. Typical endodontic case here is I think a second molar. It only had 2 canals. Here's our preparation. We get it all clean and flat, wrap that band around. You can see the rib-on into each of those canals. That gives us a little bit of a matrix to put the, so that we can put the composite in. Here is the bio base, our preparation, and here are our castings. Biomimetic casting made from porcelain or from Emax or pressed ceramic. You can do them from any number of different materials. Quadrant restorations. This works beautifully for quadrant restorations, regardless of how destroyed the teeth seem to be. Look how nicely we can protect those gingival tissues there. Sometimes patients come in and we have a case where we have occlusal effect caries here. You can see on the mesial we're developing caries, but we're also losing that mesial buccal cusp. You can see our rib-on flat against the preparation. Here is the final prep, and what I did here on my good friend Lenny is I bonded on a cast gold partial coverage restoration so that we preserved some of the cusps, and he certainly is able to chew very nicely with this, and once again maintaining as healthy gingival tissues as we can. Here you can see sometimes in a little bit more critically cosmetic areas, here like this upper first premolar, we can create a very nice result cosmetically. Here on the bottom, we can also create a very nice result. You can see the crack into dentin from the mesial. You can see that this restoration is failing. Here is our final preparation, and here is the final result. Once again, maintaining the integrity of the periodontium and avoiding endodontics. In conclusion, let's talk a little bit about what we are accomplishing here. We have a simplified technique. We often don't need a provisional. Once we inform the patient that their tooth is going to feel shorter, and then when they get the final one, it's going to feel a little different, but they do adapt to it. So for one or two teeth in a quadrant, it's no problem. We are creating biologically and mechanically compatible restorations, and this is critical, that we are not creating something that is going to destroy the tooth substrate. We avoid endodontics. Now, I have done biomimetic restoration since 2008, early of 2008, and here we are in 2015. I have had one tooth require post-insertion endo, and it was a necrotic tooth, so it was just simply a misdiagnosis at the beginning. But we do not get post-operative pain. We do not require post-operative endodontics. We avoid some, but not all, periodontal crown lengthening. If you can get a matrix band, or if you can get the material, if you can get the tissues isolated, then you can create a healthy restoration without doing the periodontal surgery, because the periodontal surgery has its set of problems too, such as an increased chance of endodontics. We create a fail-safe restoration. So if something goes wrong, if you get decay, it's going to happen up high at the interface between the tooth and the casting. It is not going to happen interproximally, where you've taken great care to place the composite, where you have a gap that's only angstroms in size and not microns, keeping in mind that bacteria are about 1 micron in size, so if the gap is smaller than a bacterium, then you're good. Remember that the intact tooth is our guide to restoration, so we're going to recreate the enamel, the dentin, and the interface between the two. And that gives us a very bendable, a very serviceable, and a very comfortable restoration. With endodontic teeth, we are strengthening the tooth restoration complex. We are avoiding posts and all of the complications that occur with posts. We are creating a fail-safe restoration so that we are not going to be finding crowns broken off and the patients walking in with the crown in their hand saying, "You just put this crown on 2 years ago, doctor. Why did it break?" They don't require the provisionals. And very important, we protect the treated canal from crown down microleakage. We don't have microleakage in these kinds of cases because the interface between the composite and the dentin is tight. It is not going to, you're not going to get shrinkage, and you're not going to have an opening that the bacteria can march through there. My name is Randall Cohen, and this is my email address. If you have any questions or anything that you'd like to ask me, you're welcome to send me a note. If you wanted this program for a study club, it is also available for study club presentations. Once again, I want to thank Septodont for their sponsorship. Thank Viva Learning